So we have to take a nephrologist opinion, and then only we have to jump into the RRT therapy. So the cases where RRT is helpful is if the patient is having refractory volume overload or acid-base imbalance, significant acid-base imbalance, and electrolyte abnormalities which are not corrected pharmacologically, then we have to go for RRT. So mean arterial pressure, we know in septic shock it is maintained around 65, hemorrhagic shock around 55. In cardiogenic shock there is no data, but some of the recent studies they say it should be more than 70 mm of Hg. So in a patient with cardiogenic shock, we should try to maintain the mean arterial pressures more than 70 mm Hg over the first 38 hours. So hypotension is not equivalent to microcirculatory dysfunction. Both are different entities. So to know the microcirculatory dysfunction, there are some parameters which we have to, there are some surrogates of microcirculatory abnormality, that is serum lactate levels, arteriovenous carbon dioxide gap, and capillary filling time. So these entities we have to check, and there are some that are going on in the studies, but their role is limited practically. So coming to the serum lactate levels, so normal serum lactate is less than 2 millimoles. So if it is increasing, or the time taken for the increase and also for the decrease of lactates, both are important, and if the time taken to come to baseline, if it is more, it means that the survival rates are poor. Lactate clearance is a very important marker in cardiogenic shock, and it is a prognostic indicator. There are very few indicators prognostically in cardiogenic shock, out of which one is lactate. I think time. So any patient who is having deterioration in the lactates, we have to take the mechanical circulatory support. So metabolic acidosis is an important entity wherein most of the metabolism happens anaerobically in a patient with shock. So all the factors which increase the acid level in the body will be more, so that the patient will be having increased base deficit and increased anion gap. But in a case of cardiogenic shock, an important prognostic factor is the base deficit. If the base deficit is more, it means that the prognosis is poor. So I told you we can measure easily the central venous oxygen saturation and also the mixed venous oxygen saturation. I think these are maybe for the audience slightly complicated. I don't want to go into these parameters. And right ventricular and left ventricular pressures, for monitoring these LV and RV pressures, these are the right ventricular parameters. So if we put a central venous line and also a PA catheter, so that line will have a port in the right atrium, pulmonary artery, so and also a wedge pressures and also the right atrial. So this is the 3-axis model, which is a conceptual model wherein the cardiogenic shock patient, we have to see all these 3 entities. One is the severity, which we discussed till now. The other are the risk modifiers. So as in heart MI patients, we do have risk modifiers for cardiogenic shock also. So if the patient is post cardiac arrest, it means that it is a high risk, he is a high risk patient. Similarly, the age is high, more, then the patient is high risk. If the patient is having organ dysfunction, high risk. SIRS, high risk. So like that, these are the risk modifiers. And coming to the next thing which is important and upcoming is the phenotype. So we have to see the phenotype of the patient, wherein these parameters are included, which is the etiology. if the patient is having cardiogenic shock, which is as a result of ischemic cardiomyopathy, it means it is a worse prognostic factor, which are included in this 3-axis model. Any patient who you have got in the ICU, put this chart, triangle, and see whether the patient is is having a good prognosis or poor prognosis. So this is the management. If the patient is in stage A, this is targeted therapy. If he is in stage B, then if the patient, then we consider it as pre-shock. So here comes the role of monitoring, checking the lactates, and initiation of the vasoactive drugs, and role of IABP, that is intra-aortic balloon pump in selected patients. That is in ischemic cardiomyopathy or in acute MI patient, we have to start IABP. So in stage C, we have to shift the patient to a cardiac ICU, and we have to take the consultation of the shock team. So we have to go for invasive hemodynamic monitoring, and we have to start the dopamine, milrinone, whatnot, all the inotropic drugs and the vasopressors. So next comes the stage D. So if the patient is in this stage, after consulting the shock team, we have to shift the patient to the shock ICU, and there comes the role of mechanical circulatory support. So phenotyping I just discussed. So I think the time is running, sir. Should I conclude? So subphenotyping also is there. I told you about the phenotypes. Subphenotyping according to the traits of the patient. So in the treatment modalities, these subphenotypes are also important, and we have to go into multiple factors of subphenotype, wherein mechanisms of subphenotype individualizing the patient. Now we are going through the clinical trials. This is the current approach where we mix all the patients together. So modifiable, non-modifiable risk factors, all the high-risk patients, low-risk patients. So one size will not fit all. So now what we are doing is, we will do one intervention and check in all the subgroups and see it is acting properly or not. But if there is no, now the emerging approach is staging approach, but the futuristic approach is the subphenotyping, where we can individualize the patient and give the treatment accordingly. So mechanical circulatory assist devices, Samosa will discuss. So these are the assist devices that are available. So in summary, cardiogenic shock manifests in a heterogeneous severity and several clinical phenotypes. Shock classification stratifies shock severity and predicts the mortality. Risk modifiers can improve the mortality risk stratification beyond severity. Phenotypes can be integrated into standard measures of cardiogenic shock severity, and subphenotyping can identify the specific treatable disease processes. Thank you.
The various components of ECMO, a brief physiology behind different ECMO approaches, identifying which patients are potential candidates for ECMO, and few interesting clinical scenarios that we face in our daily routine in which ECMO can be used. Before starting off, let's go through some of the short forms. What is ECMO? ECMO stands for extracorporeal membrane oxygenation. There are types, VV ECMO and VA ECMO. VV stands for venous extracorporeal membrane oxygenation, while VA stands for arterial extracorporeal membrane oxygenation. There is another terminology called ECLS, extracorporeal life support, and ECPR, that is extracorporeal cardiopulmonary resuscitation. Machine with two capabilities, both a pump that is functioning as a heart and a membrane oxygenator which functions as a lung. So blood is taken from the patient into this machine, oxygen is added, carbon dioxide is removed, and blood is pushed back into the patient. Which patients? It is basically, one has to remember that ECMO is not a curative treatment. It is only providing rest to the heart and the lungs and gives us time to address the cause for the problem, whether it is cardiac or respiratory. So it's a temporary maneuver, gives rest to the heart and lungs, allows us to intervene and treat the primary cause, and that's how patient benefits. Now this is the primary basic circuit of an ECMO. Starts off with the blue one. Blue one is the drainage line, and this is the return. So blood is drained from the patient using cannula and tubings into a machine. This is the pump which functions in the heart. This is the console which controls this pump. And from the pump pushes the blood into an oxygenator. The oxygenator has a supply of oxygen and removal of carbon dioxide. And once that is done, blood is pushed back into the patient. So these are the components. There will be tubings, circuit, pump, or console, oxygenator, and again tubings. Now these are some of the equipment that we use. The first one is the cannula. Now generally we don't call cannula in this as arterial and venous. We'll come to that why. So we address them as access cannula and return cannula. So any cannula which drains blood from the patient into the machine is called the access cannula. And the cannula which helps in pushing blood back into the patient is called the return cannula. So access to the machine and return to the patient. That's how we address the cannula. So if you see the top diagram, that's a small, that is basically a short little cannula. Length is around 23 to 25 centimeters. These are So these cannulas are primarily used for arterial cannulation, so return cannulas. Okay, then here the lower one is something called as a dual stage cannula. We'll come to that also. This will have, basically it's a Y-shaped cannula. If you see this one, so if one will be color coded blue and the other one is red. So one will be an access and the other one will be return line. This basically has three openings. One will be at the tip, this is the distal most, this is the proximal most, and one in the middle. So the proximal and the distal will basically act as the drainage system, while the middle one will be the return system. These are classical venous cannula. They are long in length, generally 55 centimeters in length, and they will have multiple openings, not only at the tip, but also on all the multiple side holes will be there. These are primarily done so that it is better venous drainage into the circuit. This is how a console looks. Basically, there are two companies, Mackey and Meadows, which provide the ECMO consoles. This was the first machine which came by Mackey. This is called as a Rotaflow. So basically, it consists of a console. Now, this console has basically two values. One will be revolutions per minute, that is the speed in which the pump rotates, and the other one will show you the cardiac output, the flow, liters per minute. This is the knob which is used to adjust this. This is basically a temperature control machine through which connectors are made with the oxygenator, and it will help us to maintain the temperature of the blood which is being removed, because every time blood comes out of the body, patient is going to lose heat. And if you send the poor blood back, hypothermia will lead to again myocardial issues like depression and arrhythmias and all that. So you need to warm the blood to room temperature, to body temperature, and then push it back. So this is the temperature machine. This is how the whole unit looks. So this is your console, this is your temperature regulator mechanism, this will be your blender, and this is the stand for the pump. This is how a compact system that it works. This is the other advanced version by Mackey called the Cardiology. Now here what happens is, in the previous one, the oxygenator and the pump are two separate. Here it is incorporated into one system. So this is a combination of a pump as well as the oxygenator. And this is how the system looks. This is called the Cardiology system by Mackey. This is the system by Meadows. This is what we have. Again, this will have a console which will control the pump, a blender and monitoring system. Then this is the pump which will function as the heart, and this is the oxygenator. These pumps are generally centrifugal pumps, so there are impellers inside which through magnetic levitation they rotate, and that's how they propel the blood forwards. This is how the circuit works. Okay, so from the patient through the access cannula, blood is brought to the pump. The pump pushes the blood into the oxygenator, where oxygen is added, carbon dioxide is removed, temperature is regulated, and from the oxygenator, again blood is pushed back into the patient. This is how an ECMO circuit generally works. Coming to types of ECMO. Types of ECMO have various classifications. The basic classification will be based on two. what is the reason for which you are initiating it, and what is the approach that you are using for initiating ECMO. So based on the etiology, if there is cardiac failure or there is cardiac respiratory, mixture of both heart and lung failure, then the type of ECMO that you use is VA ECMO, veno arterial ECMO. However, if there is exclusive respiratory failure, when the lungs are not working but the heart is functioning normally, remember, heart is functioning normally, that type of ECMO would be venous ECMO. Now in this terminology, the short form, there is a sequence to it. The first letter, that is in VA, the first V refers to the axis. Whatever is your axis, that will be the first. And the second one will be your return. So VA means blood is being taken from the venous system and pushed into the arterial system. VV means blood is taken from the venous system and pushed back into the venous system. Then based on the route that you use, you can use it either through a peripheral insertion, either a femoral route, jugular route, or an axillary route, either surgically or percutaneously. That would be called as a peripheral ECMO. Central ECMO is done using sternotomy. So you do a sternotomy, you cannulate the right atrium and the aorta and initiate ECMO through that. Let's go to some of the configurations. Okay, now let's start off with veno-arterial ECMO. The classical veno-arterial ECMO, the simplest form of veno-arterial ECMO is a fem-fem ECMO. That means you cannulate, if you see this diagram, blue is the venous side, red is the arterial side. So you cannulate the femoral vein on one side, the tip will be somewhere close to the IVC-RA junction. Blood will come out from that, go into the pump, oxygenator, get oxygenated, and go into the femoral artery. The tip of the femoral, as I said before, the arterial cannulas are small length, so the tip will be the common iliac. Now here an interesting point that there is a curve here. What happens because you're cannulating the femoral artery with the size of around 17, 19, 21 French catheter, there is a chance of distal limb ischemia. So always in VA ECMOs, when you are initiating to the femoral root, you need a distal perfusion catheter size of around 8 to 9 French to perfuse the lower limb on that side. So this is a classical. Now here, how does it work? When you are, remember that you have one cannula in the femoral vein and one in the femoral artery. So you drain blood through that. But you are unable to drain the entire blood. So some amount of blood will still circulate into the native heart and native lungs. So some amount of blood will come from the SVC to the RA, go into the RV, go into the native lungs, come into the LA, LP, and then get pumped out of the aorta. So here what happens is because there is retrograde flow from the pump circuit, that is from the femoral artery, blood will go up. The lower part of the body will be perfused from the ECMO circuit, but the upper part will be perfused by the native heart. Okay. The target in a VA ECMO is generally to achieve 80% of the native cardiac output. That should be the goal. But again, this machine is dependent on the drainage. Depending on how much drainage comes, you can only give a maximum flow for that drainage. So suppose if you are not able to give enough drainage, the upper body will be perfused by the native heart. Now, if the lung condition is bad because patient is in cardiogenic shock, pulmonary edema, then lungs will not be able to oxygenate the blood which is flowing from the RV to the lungs and to the left side. So what will happen is the upper part of the body will get significantly deoxygenated blood, while the lower part of the body will get adequately oxygenated blood. So in this type of fem ECMO, VA ECMO, there is a chance of myocardial ischemia because coronary will get perfused by more deoxygenated blood. Also, there is a chance of cerebral hypoxia also occurring. To deal with this, you have to give higher flows. How do you give higher flows? You get more drainage. To get more drainage, you insert another catheter or cannula into the SVC. So this diagram indicates that. So here what we have done through the IJP, we have put another access cannula into the SVC. So this will drain more blood. So because the drainage is more, you will be able to give higher flows. So less chances of cerebral as well as myocardial ischemia. So this is the distal perfusion. By putting the distal perfusion, now this is the distal perfusion, this is the normal femoral artery which is cannulated. Only one precaution that needs to be taken is that distal perfusion catheter should be very close to the femoral puncture site. Because remember, the area of the femoral artery between this puncture and the distal perfusion is not getting perfused. So the longer the distance, there will be a chance of clot formation of the femoral artery there. So that is one precaution. To deal with this, what we can do is, instead of putting the cannula directly into the femoral artery, we suture in a graft to the femoral artery. So if you suture in a graft to the femoral artery, you don't have to put the distal perfusion catheter. This is how it looks. So this is a real-time photo. So this is the femoral artery cannula, and this is the distal perfusion, very close to each other. Coming to central cannulation. Central cannulation, as I said, you do a sternotomy and you cannulate the right atrium for the venous access, and then again blood will flow to the pump, go to the oxygenator, and go back into the aorta. The major problem of this is one, you have to do sternotomy. One, so risk of chest will have to be kept open. So risk of infection. Also, there is a high risk of bleeding in this because all the pericardium will be open, the sternum will be open, you will be appendicing these patients. So greater risk of infection and greater risk of bleeding in these patients. So to deal with this, there are specialized cannula now available which can be tunneled into the chest wall. So you tunnel those cannulas to the chest wall, do a sternotomy, cannulate the RA, cannulate the aorta, and then close the chest. So the risk of infection and the risk of bleeding goes down significantly. But again, this would still be a type of central cannulation because you are cannulating the RA and the aorta. Now this is a new modality which is fast picking up, use of ECMO in eCPR. That means when you are giving CPR, we will discuss this more in detail, just to give you a brief overview of what is happening in this diagram. Is patient is arrested, you are giving CPR, patient has some return of spontaneous circulation, but he keeps going back into arrest. So in those modalities, ECMO can be a very good choice. The only difference here is because time is of utmost importance during CPR. You don't waste time putting a distal perfusion catheter. Because distal perfusion catheter you are putting in the opposite direction is more difficult, very time consuming. So you don't have enough time, you don't waste your time putting a distal perfusion catheter. So from below, so this is called as retrograde flow. Now because of retrograde flow, what happens is, one, the systemic, the afterload to the ventricle, left ventricle will be high. And blood is flowing. Remember, the heart is ejecting like this and blood is coming from below. So there will be a lot of resistance to LV emptying. So the chance of LV dilatation occurring. Okay, now because of this, there will be increase in LV end-diastolic pressure. This pressure will get reflected into the pulmonary circulation, and patient pulmonary edema can actually worsen in these conditions. Okay, so that is one point you got to remember. Second, obviously, the chance of limb ischemia is always there with the VA ECMO, especially if you are putting in a femoral catheter. Because you are putting a fen-phen cannulation and the coronaries are getting perfused by the native lung and the native heart, it is important that your ventilator setting should be adequate to achieve good oxygenation. But suppose despite all this you are not able to achieve good oxygenation, or then what you are supposed to do is go for the femoral cannulation and the SVC cannulation for venous return and increase the flow. If you increase the flow, the flow from the femoral artery will be able to reach the proximal part of the aorta. So that will take care of the hypoxia which is occurring to the coronary. There is another thing also called Harlequin syndrome or north-south syndrome. Same. When the heart is recovering but the lung has not completely recovered, heart will keep ejecting. When the heart is recovering following a cardiogenic shock, it will eject with greater force. But the lungs has not sufficiently improved, so oxygenation will continue to remain compromised. But because the heart is ejecting vigorously, the proximal part of the body will get perfused by deoxygenated blood coming from the heart. So you get cyanosis in the upper limbs, but you will get pink peripheries in the lower because that is coming from the ECMO circuit. So that is called as differential hypoxia, Harlequin syndrome or north-south syndrome. Okay, the treatment of this is again either you increase the level of drainage, so you put extra venous side cannulae and drain more blood and gives more flows, give adequate ventilation to the patient, adjust your ventilation strategies so that lung gets better oxygenated. If nothing works, sometimes you might have to convert a peripheral to a central ECMO so that you cannulate the aorta. Now myocardium will get supplied, the coronaries will get supplied by oxygenated blood coming from this. So the last measure is putting in a central ECMO. So this is about a brief in physiology about VA ECMO. Now coming to some of the configurations of VV ECMO. As I said, venous ECMO. The standard and the most simplest one is femoral. So cannulate femoral vein on both sides. One will drain the blood and the other will return. Now remember that the drainage cannula will always be lower placed while the return cannula will be higher placed. Okay, so generally in fen-phen VV ECMO, the tip of the return cannula will be somewhere close to below the IVC-RA junction, while the return circuit oxygenated blood will enter the RA. Now here what happens? You are draining blood and you are pushing blood. The amount of blood that is drained is the amount of blood which is going in. So no hemodynamic alterations will occur. But remember that the cardiac output, this blood will enter the RA, oxygenated blood, it will pass to the lungs, come to the LV, and the LV will eject this blood. Hence, in VV ECMO, LV function has to be normal because the patient's cardiac output is being maintained by his own heart. Hence, VV ECMO cannot be used in patients with any type of myocardial dysfunction. Okay? Otherwise, if you are using it in myocardial dysfunction, what will happen? You are giving great flow to RA. So it will work as if there is RV volume overload. All that blood will go into the lungs, and instead of your oxygenation improving, patient will go into frank pulmonary edema and worsen. Okay, so VV ECMO, the golden rule is heart rate should always go in echo and document that the heart is functioning normal. These are some of the other configurations. Instead of femoral vein and femoral vein on both sides, you can get femoral vein on one side and you return the blood to the jugular, into the artery. This configuration will be a femoral jugular configuration. Okay, then suppose sometimes you do this but you are not able to achieve adequate saturation. As I said, the pump flow will depend upon always how much blood you are withdrawing. With one cannula, you may not be able to withdraw sufficient blood to give high flows. If you are not able to give high flows, then your oxygenation will not improve significantly. So the whole idea of giving VV ECMO may not be possible. So in that case, what you do, increase the drainage more so that you are able to achieve higher flows and greater amount of oxygenated blood can be given. So in that, you go for what is called as bi-cavo-atrial. So you cannulate the SVC, take the blood back from the SVC, take the blood from the femoral vein and return both the blood. So this is the Y connection. See, this is the venous side. You see, this is the Y connector. One is draining from the femoral vein, one is draining from the SVC. And you pump the blood, you will be able to give higher flows, and you pump the blood back into the RA, so you will achieve better saturation. Okay, so this is the return one. So you have two venous side, one is the SVC, one is in the femoral vein, and you return into the RA. So this is called as a bi-cavo-atrial. The major advantage of this is you will be able to achieve more oxygenation in these patients. And there is another thing, we discussed a dual lumen catheter. So there the catheter has a Y connection. So it's a Y-shaped catheter. One will be access and one will be return. Again, the major advantage of this is you can insert the cannula through a single port. So generally, IVC, the internal jugular vein is preferred. So as I said, the proximal the distal most opening will be in the IVC. The proximal most will be in the SVC. And you return the blood to the middle port, which is very close to the tricuspid valve. Okay, so you achieve good return and good flows. So this will give dual lumen VV. Now this is how the patient of FEM looks. This is a VV ECMO initiated through the femoral route. This is the femoral vein. The dark colored blood goes into the pump, oxygenation, and then oxygenated blood comes back to the femoral artery. This is how FEM cannulation looks. Now what is the physiology? We have already discussed. Oxygenated blood will go into the RA. Then it will move through the RV, pulmonary circulation, go into the LV and get pumped out. Therefore, the heart function has to be normal. The cardiac output in these patients is maintained by its own heart. And because the amount of blood removed and the amount of blood pushed back is the same, there will not be any hemodynamic alterations in these patients. Therefore, the only thing that you achieve by VV ECMO is improving oxygenation and removing carbon dioxide. There is no other cardiac support being given by VV ECMO. So just to summarize, the functions of an ECMO is basically oxygen delivery. Now what are the factors which affect oxygen delivery? One will be, see, there are two ways of oxygenation. One is through the ECMO circuit and one will be the native heart. So the factors which are affecting is obviously what type of circuit and the flow that you are giving. Besides this, what is the venous saturation of this patient? The FiO2 that you are giving. The type of membrane oxygenator and the amount of gas exchange area, because different oxygenators have different gas exchange areas. The larger the gas exchange area, the more the oxygenation. What is the baseline hemoglobin of the patient and how much blood flow corresponds to cardiac output. So what is the blood flow that you are giving? Higher the blood flow, more the oxygenation. So these are the factors which will affect your oxygen supply in ECMO circuit. Coming to removal of carbon dioxide depends only on one factor, and that is the total gas flow rate. Remember we discussed about the blender wherein you give oxygen to the patient. So what is the total gas flow rate? The higher the gas flow rate, the more carbon dioxide will get washed. So that is called as the sweep flow rate. So carbon dioxide removal only depends upon the sweep flow rate. Now when do we use? This was about what of ECMO. When is ECMO needed? So basically, grossly you can classify ECMO requirement into two categories. Patients who have potentially reversible but life-threatening respiratory or cardiac illnesses which are unresponsive to maximal medical therapy, or it could be an irreversible form also, but then that patient is a candidate for a ventricular assist device or a lung or heart transplantation. So in these scenarios, you can use ECMO. But before initiating ECMO, you have to answer a few questions. First, what is the type of failure? Are you dealing with a heart failure? Are you dealing with a respiratory failure? Or are you dealing with a mixed failure? Second, is the condition reversible? And if it is reversible, what is the time frame that you are looking at? Whether you are looking for 5 days, 15 days, 21 days, or a longer duration. And if the condition is irreversible, is the patient suitable for any other therapy? Like let's say transplantation, is it an option? Then that question has to be answered. Now based on that, ECMO can either be used as a bridge to recovery. That is either for some other, let's say surgical, let's say cardiogenic shock patient has got an acute MI, we do an angio, we know that there is a treatable coronary artery disease. But patient is unstable, so you put them on ECMO, take them up for stability surgery or primary PTCA, and continue ECMO, patient stabilizes, you wean off ECMO. So that would be called a bridge to recovery. Or whether it's a bridge to receiving organ transplantation. Remember where we discussed patient is an irreversible condition, but is suitable for a transplant. So those conditions also you can use ECMO, wherein it will be used as a bridge to transplantation. Or sometimes we are ourselves not sure whether this patient will benefit with some medical therapy, from some surgical therapy, or whether the patient going forward will become a candidate for transplant. So in that case also you can initiate that. That time it will be called as bridge to decision. So you initiate that, stabilize the patient, do all your investigation, then decide whether the patient will need some advanced medical therapy, some advanced device therapy, surgical therapy, transplantation, or nothing. In that case, we'll discuss what should be done in those manners. That would be called a bridge to decision. So once you have decided that, then you can customize. You discuss the various configurations. So that is what is customization. Whether you want the veno-venous, you want the veno-arterial, what is the type of configuration? You want fem-fem, you want fem-jerk, you want fem or axillary artery, or you want triple cannulation, dual cannulation, that you customize your configuration. This will depend again, as I said, depending on how much oxygenation you want and how much circulatory support, meaning how much flow you want. The larger the flow, the more the venous side has to be cannulated, because unless venous drainage is more, you will not be able to give greater flows. Also, it depends upon what is the type of anatomy. Patient has some femoral blockages, you cannot cannulate the femoral, then you have to go for axillary. Okay, then if the size of the vessels is small, so ideally before cannulation you should also either do a check shoot if the patient is in the cath lab of the femoral vessels, or at least using ultrasound, check the diameter of those vessels, artery and vein. That will help you in deciding which side you should cannulate. And also ultimately it will depend upon the age, weight and height of the patient, because the flow is directly proportional to the body surface area. Now coming to now indications. So these are some of the indications. Let's start off with BA ECMO. The dark circles are those indications wherein there is clear-cut evidence that ECMO is beneficial. A lot of RCTs are there. There is absolutely no doubt there. While the light ones are upcoming indications where ECMO is going to be beneficial, but not as much as the darker ones. So which are the darker ones? Acute myocardial infarction leading to cardiogenic shock. Myocarditis, especially of viral origin. Patient after cardiac arrest, especially if you are able to give CPR and patient shows ROSC within 10 minutes. Post-heart transplant, it is primary graft dysfunction. Post-cardiac surgery, patient goes into cardiogenic shock. Or drowning-related hypothermia, which leads to myocardial depression or rhythm disturbances. Now, some of the other conditions could be patient with malignant arrhythmias or postpartum cardiac myopathy. Acute pulmonary embolism, post-trauma with lung contusion or myocardial contusion, postpartum cardiomyopathy. Certain drugs can produce severe myocardial depression or they can be arrhythmogenic. So those drugs also you can use. Sepsis and in some conditions of cardiological procedures. Like it can be used in intervention cardiology, high-risk procedures for high-risk PCIs, patients undergoing TAVI with poor LV, microclip procedures, or patients having malignant arrhythmias. Sometimes it can also be used as a bridge to therapy, like post-MI, patient develops a ventricular septal rupture, a papillary muscle dysfunction, LV free wall rupture, or acute endocarditis leading to cardiogenic shock. So these patients also you can initiate. And some of the rarer conditions could be any of these metabolic conditions like severe diabetic ketoacidosis, thyroid storm, pheochromocytoma, Takotsubo-type cardiomyopathy, malignant arrhythmias, postpartum cardiomyopathy. Now, what are the indications for VECMO? Commonest indication is ARDS, whether it is infectious in origin, whether it could be traumatic pulmonary contusion, or following aspiration pneumonia, primary graft dysfunction following lung transplant, or whether it is an autoimmune type of pulmonary vasculitis. Now, one very important indication for VV ECMO is if you feel that patient has severe acute respiratory failure, you want to refer the patient to a higher center, but patient is extremely unstable, requiring very high airway pressures to ventilate. So that for inter-hospital transport, also VV ECMO is indicated. So you put the patient VV ECMO, stabilize the ventilation parameters, become significantly easy, because otherwise what happens the moment you disconnect or any change in the ventilator, patient will desaturate and arrest. So inter-hospital transport is a very important indication of VV ECMO. And sometimes, rarely, in status systematica, smoke inhalation injuries also to give rest to the lungs, you can use VV ECMO. So basically, VV ECMO, any condition which leads to inability to maintain saturations more than 88% or pH more than 7.2 despite maximum ventilatory efforts with plateau pressure up to 35, adequate tidal volumes, high peaks, recruitment maneuvers you have tried, prone positioning you have tried inhaled oxygen, nitric oxide, given adequate cardiac support, prone ventilation. So remember that before thinking about VV ECMO, you have to initiate these maneuvers and see whether the patient improves. Not like you have just tried something and increase the FI of the patient not improving, refer for VV ECMO. No. You try these maneuvers, see whether the patient is improving. If patient is not improving, then it's an indication for VV ECMO. Now, what are the contraindications? This is the general contraindications. Extreme age group, age level more than 75 years. Patients with neurological injury. Any patient who is not conscious is not a candidate for ECMO. Patients needs to be neurologically stable, responding to commands. Then they can be indicated for ECMO. Patients with malignancy, with presence of severe chronic organ failure. These are some of the absolute contraindications. Patients with unrequired aortic dissection. Because you are going to candidate the femoral artery with dissection, patient will get finished the moment you candidate. And severe AR, we discussed about retrograde flow. Afterload is more. If the flow is coming like this, if there is aortic regurgitation, all the blood will go into the left ventricle. Heart will distend, patient will arrest. So severe AR also is one of the contraindications. And patients presenting with late cardiogenic shock, very high lactate, severely anuric for multiple hours, patients with hepatic failure, there are contraindications for. Now let's discuss some of the other ones, indications for ECMO. eCPR. Now there are ongoing efforts to improve outcome of cardiac arrest. So eCPR is indicated in all patients who remain in cardiac arrest despite all our conventional CPR efforts, or when intermittent return of circulation occurs, but patient keeps going. I mean, you give CPR, patient recover, this ROSC goes back into arrest. So recurrence is there. In those conditions, eCPR is indicated. Now, by itself, eCPR will not provide any favorable outcome. You have to go by a protocolized approach wherein you give CPR, you pull down the patient, you put them on ECMO, go for any therapeutic measures like early if there is a coronary artery disease or cardiogenic shock, you go for early reperfusion. Therefore, you've got to use eCPR only if you think there is a likelihood of clinical benefit based on what is the suspected diagnosis that you have. One. Second, it can be only done in institutes wherein there is a team with adequate training and expertise. Or in some circumstances, you can initiate ECMO CPR if patient is a potential organ donor. A lot of us sometimes give a will saying that yes, when we die, we want to donate our organs. So those patients also ECMO is indicated. How does it work? It basically provides better blood flow compared to conventional CPR. It is, as we discussed, it's a bridge to appropriate therapies in patients in cardiogenic shock. We put them on ECMO, stabilize, take them to cath lab, do an angio, see what is there. If there is a critical condition, to treat it. It gives rest to the heart, allowing fast recovery. There are lesser need for inotrope vasopressors, so less drug-induced toxicity. Any reversible cause, whether it is metabolic, organic, can be diagnosed and you can treat it. It is known to produce better neurological outcome, and the best part is ECMO CPR can be initiated everywhere, right from emergency room to your operation theatre, to your ICU, cath lab, anywhere. Now, what are the indications? This is very important because patient's age should be less than 65 years with no pre-existing severe comorbidities. It should be a witnessed arrest. So the best scenario is an in-hospital cardiac arrest. And when you're giving CPR, patient shows signs of life. Signs of life meaning responding to command, pulse comes back, patient starts breathing. So those are signs of life. Then, if the no flow time is less than 2 to 10 minutes, what is no flow time? No flow time is the time from onset of arrest till the first effective compressions start. So that time should be less than 10 minutes, then you can consider ECMO CPR. Or if you have the capability of initiating ECMO in less than 75 minutes of the arrest, then you can take up the patient for ECMO CPR. And generally, non-cardiac causes of arrest do poorly. So cardiac causes of arrest, ECMO CPR has better results. But in drowning leading to hypothermia and drug intoxication leading to myocardial depression or arrhythmias, ECMO CPR is indicated. Now, what are the exclusion criteria? The first one, obviously, we discussed out of hospital cardiac arrest. Nobody knows when the patient arrested. You don't exactly know whether there is no timeline there. Those patients not to be done. Or if the patient is fully conscious after an arrest time, although patient may be hemodynamic unstable, that is not the time to initiate ECMO CPR. Okay. Or if patient has a suspected stroke or intracranial bleeding, pre-existing chronic organ dysfunction or some bleeding disorders, or if it is an unwitnessed arrest. Again, same thing. Nobody knows what time patient is arrested, so we are not sure what is the no flow time. So those conditions, don't put them on ECPR. This is another indication for trauma. Now, trauma, blood chest trauma can lead to myocardial contusion, lung contusion, ultimately leading to ARDS. So in these conditions, generally ARDS can occur in around 5 to 10% of these patients. And if ARDS occurs and if left untreated, oxygenation gets affected, and they will have a higher mortality of up to 20%. So these patients, you can try ECMO. Only thing is you have to rule out that there is no intracranial hemorrhage. These patients should not require any surgery like an orthopedic surgery to fix something, and there should be no solid organ injury. Meaning there should be no liver injury, no kidney injury, because what happens if there are injuries, you put them on ECMO because of weaponization, they can have intra-organ bleeds. So patient can suddenly crash. And better prognosis is definitely seen if patient is younger age group, if there is a reversible disease process, if you diagnose early. Otherwise, prior to that episode, the lung parenchyma or the myocardium was free of disease. So those conditions will do better. Now there is a score called as the SAVE score. Okay, the SAVE score basically helps you to prognosticate. When you try to put the patient in, there are certain factors which you go across, and that you can roughly predict what is going to be a survival of this patient if you initiate them on ECMO. Now, what are those factors? What is the time? What is the cost of the cardiogenic shock? What is the age of the patient? What is the weight of the patient? Pre-ECMO, whether there was any organ failure. What is the duration of mechanical ventilation or intubation in these patients? What were the ventilation parameters? Whether the patient required high peak pressures, high peak. Whether the patient had a cardiac arrest prior to initiating ECMO. What was the acid level, meaning the ABC levels? What was the acid? What was the bicarb level? All those things. There are points given. You add all those points, and based on the achieve the total SAVE score. Now, based on the score, you can predict the percentage survival in this patient. So this was sometimes you can use this, and there is an online version available of this. So you download that, you just feed the values, automatically you will get a score, and it will tell you the percentage, the predicted survival of these patients also. So this can be used as a good guide when you're thinking of referring a patient. You can use this as a guide to refer the patient. Now sometimes, or rather most times in ECMO, we face certain ethical issues. Imagine a scenario: you put the patient on ECMO, heart recovers, but patient is vegetative. So neurologically patient is not there, but heart is functioning normally. What do? Or the reverse can happen. Brain is completely fine, but heart is not recovering, and multi-organ failure has set in, so patient cannot be given the option of transplant. So what do you do now? So these are some of the ethical issues. So in these scenarios, what will happen is you can't offer anything much. So basically, you're putting an ECMO, or you just have to you're just prolonging the time to death. That's why before initiating ECMO, other than answering all those questions, you always need to have an exit plan. And this has to be conveyed to the relations while counseling. What are you expecting? Are you expecting improvement? And what if improvement does not happen? What are you going to do? You just can't put the patient in ECMO throughout his, for weeks together. So an exit plan helps you to cover up for these ethical issues. So generally for cardiac ECMO, that is VA ECMO, they say patient should benefit within 3 to 4 days. So 96 hours generally is a cutoff for patient to show signs of improvement following cardiogenic shock or following initiation of VA ECMO. If patient is not showing signs of improvement by 4th or 5th day, then you have to start considering these options. So this counseling has to be given to the patient's relatives before you initiate cardiac ECMO. Similarly, respiratory ECMO, although it has better results than cardiac ECMO, but respiratory ECMOs are generally longer duration, so 2 to 3 weeks. You can't expect respiratory improvement occurring in 5 to 7 days like a cardiac cough. So you have to be ready to put those patients on ECMO and counsel the relatives accordingly that this is going to be a long-term maneuver. Improvement will be seen over weeks. Minimum 15 days to 3 weeks run of ECMO is required. So this counseling will help you to deal with these ethical issues. And if after all this patient is not showing signs of improvement because you have already decided on an exit plan, counseling the patient, you are justified in withdrawing ECMO as long as you document it before initiating the ECMO. So the take-home points, just summarizing the whole thing, ECMO is a powerful tool but always have a destination or an exit strategy in mind conveyed to the relationship before initiating ECMO. ECMO definitely improves survival in respiratory cases compared to mechanical ventilation alone. It can be performed in the variety of patient population right from neonate to adults. It needs to be customized based on the patient's own condition and the clinical cause for the deterioration. And always remember that early initiation is the single most important factor determining survival or determining positive outcome. So diagnose early, refer early, call early for help. Thank you.
Is low or normal. Normal systolic function having hypoperfusion, very rare entity, but we do encounter. The stratification is based on ischemic, non-ischemic. So there is a significant difference in that, but not in the diastolic and systolic heart failure. That entity is for the heart failure classification. So the prognosis will be good if it heart failure is because of diastolic dysfunction.
One side vein, one side vein. So from one femoral vein you remove, and from the other you put it. Suppose you are not able to achieve whatever saturations are not required to be 100%. Anything more than 90% in ECMO, respiratory ECMO is enough. You are not supposed to target 100% saturation. You never achieve that. So if you are not able to achieve more than 90% saturation, you put in another access channel. So that your venous return, it's ultimately how much blood comes, how much oxygenation is picked up, the percentage of blood which is present in the body, how much of that is circulating through the machine. If your oxygenation through FEM is not improving, you put in another cannula, make more blood flow through the ECMO circuit. So you put in an SVC cannula through the IJV, increase the flow. When the moment you are increasing the venous return, the return to the pump, you will be able to give higher flow, greater oxygen uptake, more carbon dioxide washing. So that
you have any hemodynamic consequences?
nothing at all. Because your blood coming out is your blood going in. If you are removing 4 liters, you are pumping in 4 liters in the same cycle.
Okay.
So you will not give venovenous ECMO. You will not have any hemodynamic alterations. If you are getting hemodynamic alterations in VV ECMO, you check the ECG, check the rhythm. Patient will be fibrillating. Because as I said, cardiac output is being maintained by the native heart. So you have to ensure that the native heart is in normal sinus rhythm. You have to ensure that the contractility is good. Many times over a period of time, because of hypoxia persisting, you have initially initiated VV ECMO for respiratory reason. But over a period of time, cardiac decompensation can occur. That's why regular echo follow-ups are required. And if that is happening, you first start vasopressors, inotropes, whatever, depending on your hemodynamics. And if it is not working,
The patient on ECMO already, when in under hemorrhage, is stopping to do something.
sorry,
If the patient is on ADM ECMO, he developed ulnar hemorrhage.
alveolar hemorrhage.
Yeah.
Okay. If it's a VV ECMO, you just continue and wait for it to improve. Your ventilation
Will
parameters.
be activating the blood now.
Sorry.
You are already giving your anticoagulants while doing
See,
ECMO.
the ACT requirement is generally around 150 to 200 seconds. We monitor ACT every 6 hours in these patients.
Okay.
And there are reports on which use partial CPB, cardiopulmonary bypass.
Okay.
So in that, what they should do is cannulate the femoral artery, femoral vein, and go on pump. Operate whatever time it takes. After that, wean the patient off because heart function is normal. So wean them off, and that's how surgery used to happen. So patients with airway, chances of airway obstruction, especially after anesthesia, there is a big tumor. You feel that the whole airway will collapse. So those conditions, initial reports were all on partial CPB. Now they are saying instead of partial CPB, you use ECMO. There are advantages. One, it's a miniaturized circuit. So risk of the need for anticoagulation is significantly lower on the ECMO circuit compared to this. Most of these ECMO circuits which are coming now are coated with heparin. So your requirement for anticoagulation will be lesser. You can initiate it very easily pre-operatively. Okay. It can be done percutaneously from and veno-venous ECMO, so there is no problem. At least veno-arterial for repair. When you are weaning the ECMO, you need to do a surgical repair of the aorta. In veno-venous ECMO, just compression is enough. So you don't require, you can initiate it pre-operatively. If pre-operatively there isn't been an event, you can continue the ECMO in the post-operative period without compromising oxygenation and ventilation. So ECMO would be a better choice in all patients with airway surgery, high-risk airway surgeries where you think the risk of hypoxia, hypercarbia, airway collapse is going to be there perioperatively, either immediately or induction of anesthesia or when you are manipulating the tumor. And there is another advantage also. Suppose if it's a malignant tumor, If you put it on CPB, because you are going to be using suction on CPB, there is chances of systemic dissemination of malignant cells. If you are doing on partial CPB. But if you are doing on ECMO, because ECMO is separate, your surgical site is separate, there is no risk of systemic dissemination of malignant cells. So that way also using ECMO for these high risk airway procedures, especially in malignant cases, also is advisable.
Thank you.
But the size of the cannula and the tubing is significantly more. So you require higher anticoagulation. Generally for pump we say that you have to medication, sedation, whatever has to go through peripheral line or central line, but away from the central, not. Actually in venovenous they even say that central lines you should not be putting, because when you give it through central line, in BV ECMOs, both your cannulas are in the RA. While giving drug through your central line, if you inject that air will get sucked into the lines. So that is another one of the commonest means of air entry into the ECMO circuit is central line in BV ECMO. Not so much of a problem in VA because you cannulate only femoral, which is much lower, not in the RA. So you should be careful where you want your central line also. Generally we put it on the other, if you are cannulating, you put it on the other side so that there is no direct communication of air. So no interfering with ECMO circuit.
Thank you.
Is not always an issue, but it's when you're at the knob to the ventilator, then there's a gate here. You can use the gate here, enter to the arena, make use of it, but of course there's a dead end for this also. You're always stuck somewhere, that's what happens. But complications are more to be there as the ventilator, and you have this also outways that make use of it. And it needs a lot of team, that's what matters. It's not one man show, so all can spend, he was very energetic young man. He can spend whole night sitting with the patient, but you need a wonderful team to handle the whole important thing is that. Include the staff. The whole problem in and around Andhra Pradesh is nursing staff. So optimal. I'm always dissatisfied with the quality of products and quality of work commitment. But otherwise, atmosphere got its own advantage and make use of it. And then indications are sometimes liberal here, sometimes not liberal. That all depends upon the given situation. Is that highly individualized, that's what matters. The attitude of the patient, the attitude of the attendance also. Sometimes it's not easy to handle the attendance when you are on the surgical procedure. And how best you can handle them also. Emotional attitude of the attendance also matters a lot in being on the free hand. The treating problems. Now this I think I should not speak more than this. Thank you very much for the opportunity. And I thought interested in this. I became basically a primary contact pulmonary physician. That's what the word I use. Nowadays I'm not doing any interventions. But still I call the CME compulsory medical education for me. Because I was compared, I'm not interested. But he insisted, I said I'm not for these things. I'm retired evening 7 o'clock, I go to bed and make my life, but he said no, don't do that. So I could not refuse it. That's the reason I'm sitting here a dumb man. But still, I learned quite a bit. And it's a compulsory. It was compelled on me. Thank you, sir, for the knowledge. Thank you very much.
Average survival on BV ECMO in the best of centers also.
Let's not discuss about numbers because numbers depends upon the way you choose a patient for ECMO. If you choose a very same patient, your results are better. So results I don't want. There's an option. There is a good option, a reasonable option, a practical option, is a better outcome expected when you are in dead end. We are locked in ICU at dead end, it is stage night, then you are bound to lose a patient. But here is a gate where it can pass through. That is an option. It's an option. So forget about percentages outcome, who knows that? Nobody knows. I don't believe in those numbers, it's just a matter of chance. You take it, do your best efforts, give an opportunity for the patient to survive. If he survives, probably he will go. That's what matters. Because we are not looking at multi-organ failure, gun-stage, and disease, and stage, it is a problem. This is otherwise normal, healthy person, if he survives, he gets a normal. So nothing can be calculated, matters on that. Numbers I don't believe it also depends upon your choice. The Western figures are Indian figures and North Indian figures, South Indian figures, numbers depends upon so many factors. So for an individual patient point of view, in an individual setup, you look at the patient whether he deserves it or not. That's what. Very good. Hope I accept your view.
Yeah, very good. Thank you.
herself for moderating the session, and she knows to do that. Thank you, both the speakers. Thank you, ma'am. Thank you, sir. Thank you, everyone, for being here. Now we'll depart for the dinner. Thank you.